What is uvea first of all? Uvea is the middle pigmented vascular structure of the eye, which includes the iris, the ciliary body, and the choroid. So this is the iris, this is the ciliary body, and the choroid. Choroid has two parts, pars plana and pars plicatus. So any inflammation of these three structures will lead to inflammation of uvea, which is called uveitis. Another picture in which you can see the choroid. In which you can see the choroid, the ciliary body, and this is the iris. This is the iris and the ciliary body and the choroid. Okay. So the uveitis is broadly defined as inflammation of uvea, any three of the uvea parts, and it can be infectious and non-infectious. The lab investigations or any investigation for that matter will depend upon the causative. Like if it's infectious, we have to have another lab investigations. If it's non-infectious, there are other investigations for that. So uveitis is frequently associated with systemic diseases. It is a very important part is the history and review of the system, which is the first step in defining any cause of uveitis. After that, a physical examination of the eye and the pertinent organ system is must to determine the type of inflammation. Okay. So, I forgot to do the slide share more. Yeah, sorry. So, first of all, what is the medical history which is very important to take from any patient in any of the uveitis? First can be what is the time or course of the disease? Is it acute? Is it recurrent? Is it chronic? With the severity, whether it's very severe or somewhat inactive. Then the distribution of uveitis, whether it is unilateral or present in both the eyes or alternating between 1 and 2. Then what is the sex of the patient, age of the patient, and race of the patient. So the associated factors suggesting systemic conditions can be the immune system status. Is it immunocompromised patient or immunocompetent patient? Any systemic medication patient is taking, any history of trauma or travel to especially the West countries, or any social habits like whether the patient is eating raw meat, have pets at home, what are the sexual practices of the patient, occupation, and drug use. So according to the Sun group, which is a uveitis, they have divided uveitis into various categories. So the onset of uveitis can be sudden or it can be insidious. Duration can be limited. Limited is less than 3 months. Persistent is more than 3 months. And course, whether it's acute, recurrent, and chronic. For you guys, the detail may not be very, very necessary. You just remember it can be acute, recurrent, or chronic. So this was the classification based on the course. This is based on the anatomy. So anterior uveitis, intermediate, posterior, and pan. So anterior uveitis will have the inflammation in the anterior chamber, the primary site of inflammation, and this may include the iritis, which is the inflammation of the iris, iridocyclitis, inflammation of iris plus the ciliary body, anterior cyclitis, which is the inflammation of ciliary body only. Then intermediate uveitis, where the primary site of inflammation is the vitreous. Then pars planitis, posterior scleritis, highlightis will come under the intermediate uveitis. So the posterior uveitis, retina or choroid inflammation will lead to posterior uveitis. So that can be focal, that can be multifocal, that can be chorioretinitis, means the primary, the maximum inflammation is in the choroid followed by the retina, or vice versa. Then it can be panuveitis, where all the structures of uvea are involved, that is the anterior chamber, vitreous, retina, or the choroid also. So what we have to see, after the history part is over, then we'll have the physical examination of the eye. So the anterior first, taking the anterior uveitis, first is the circumlimbal or circumciliary injection or congestion, where the eye is bloody red, and around the limbus there is blood vessels and the eye is very congested. Posterior synechiae, which is the synechiae between the iris and the lens. This is because of the long-standing or acute inflammation. Cells or flare in the anterior chamber. This is due to the neutrophils which get accumulated in the anterior chamber. Mind you, the anterior chamber is otherwise quiet. In case of any inflammation, there will be cells present in the anterior chamber. Then you have the keretic precipitates, which is the deposits over the endothelium. So these deposits you can see mostly present in the inferior part of the cornea. This is because of the gravity and the aqueous which is flowing and getting accumulated in the inferior part of the anterior chamber. Another anterior uveitis sign is the hypopyon. What is hypopyon? Hypopyon is nothing but pus collection in the anterior chamber. In this photo, you can see the pus is collected in the inferior part of the anterior chamber. So these are the various signs of the anterior uveitis. You may not see all the signs in every patient. There may be some sign present in a few patients and some may not be present in one patient. So the acute signs will be, as we talked about, as we have talked, there will be congestion. There will be synechiae, which is the iris and the lens adhesions. There will be iris nodules, which are Keeps and Lusaka nodules. These are the Keeps nodules, which is at the pupillary border. Fine KPs, which is deposits on the endothelium on the back of the cornea. So these KPs can also help you determine somewhat give the idea about the cause of the uveitis. So if this is fine KPs, like they are very, very small and sharply demarcated and no color they have, so they will be mostly non-granulomatous. If they are mutton fat, like they're brownish colored, granated margins, a little larger in size, they may be a granulomatous KP. Then Keeps nodules are seen on the pupillary border, Lusaka nodules on the iris stroma. There can be band keratopathy, which is the whitish, you will see a whitish line over the cornea. These are the signs of the chronic anterior uveitis. So band keratopathy, any anterior capsular pigment because of the movement of the iris. Iris is leaving some pigments on the anterior lens capsule, which may cause pigment collection. There may not be any congestion because of chronic uveitis, because the eye has been chronically inflamed. Okay, then posterior synechiae may be acute or maybe long-standing, like chronic also. And also the posterior subcapsular cataract is a sign of chronic uveitis. So this is the huge list of various signs of uveitis. You may find this in any other book. I'm not going through all of that. You may not remember everything. Then one important thing is that each patient demonstrate only some of the possible symptoms and signs of uveitis. After history and physical examination, you have to subcategorize these patients and then accordingly investigate the patient. You don't have to advise all the investigations for every patient. That is not feasible and that is not possible for the patient also to afford so much investigations, because uveitis investigations is huge and the list is not ending. So the lab studies can determine the etiology of the intraocular inflammation, which then will help you to select what therapeutic options you have for the patient. So lab studies are never ever a substitute for a thorough physical and a history. Okay, so first step is history, then you have the examination, and then you have the lab study. So if you have to answer a question on workup of uveitis, you have to have these three broad headings under which you can fill up your pages, and also you can know that history and examination are equally important as the lab. Then coming to anatomical classification, then anterior uveitis, we just learned that it is the inflammation of the anterior uvea, that is the iris and the ciliary body. So that can be acute, sudden onset. This can be associated with the hypopyon, which was the pus collected in the anterior chamber. This may or may not be present. If it is present, it goes in favor of HLA-B27 related uveitis, in which HLA-B27 is the main investigation that you have to order. Then sacroiliac films. I have given the picture of a sacroiliac film so that you remember that you have to advise an X-ray in case you have a hypopyon acute uveitis. So hypopyon acute uveitis, you are having multiple patient is having multiple episodes. It's a young patient with hypopyon, and there are some joint symptoms. Most likely it is HLA-B27 related uveitis. So sacroiliac film is a must to order. Then, if the patient is, especially if a patient is having arthritis or back pain, then if the patient is having Ephthus ulcers with the hypopyon, it goes in favor of Behçet's disease, in which we have to order HLA-B5. But most usually we do not order because the patient cannot afford, and it is a little rarer than the HLA-B27. So that is the first investigation if you get. Then post-surgical, post-traumatic, it can be endophthalmitis, which is the inflammation of all coats of the eye except for the sclera. So in such patients, any investigation that is important is the vitreous culture. So you have to see the vitreous. If it is inflamed or it is infected, then only you will treat the patient. Okay. So that was a acute sudden onset with severe congestion. If it is a moderate severity, the eye is red and it is painful, so then you will have another history. You have to take history of shortness of breath, any African descent history. In such patients, it is important to rule out sarcoid. So how will you rule out sarcoid? You will order serum ACE. Serum ACE is the angiotensin converting enzyme, which is increased in sarcoid. You will order lysozyme, which is also increased in sarcoid. It's just X-ray you have to order in sarcoid. Just remember the pictures that I've added. You have to order these. So this is for sarcoid. X-ray you have to order. Gallium scan. Gallium scan also you can order. You have to rule out TB also in such patients, and biopsy. Biopsy of the conjunctival nodules. Sarcoid is associated with conjunctival nodules, so you can order a biopsy also. But those are the second line of investigation. First, you have to have the blood investigation and the X-ray. If it's a post-traumatic, there can be traumatic iritis. You don't have to really investigate that. Then, if it's increased IOP, usually uveitis is associated with decreased IOP. IOP is intraocular pressure. If it's increased, it may be a herpetic cause. Okay, so you have to rule out the viral causes of iritis. Then suppose the patient is you're giving steroids to treat the inflammation, but the patient is not responding or has a poor response to steroids. So you have to keep infectious etiology in the back of your mind. So first of all, the infectious etiology, syphilis is very much associated with uveitis. So I didn't find any pictures. So I have Treponema pallidum organism that you have to rule out. So you can order RPR or VDR for screening or for monitoring or for prophylaxis, monitoring. And for confirmatory, you have to have the FDA BPA's confirmatory test for syphilis. Now, if there is uveitis post-cataract extraction, there may be a low-grade endophthalmitis, which is IOL related. So yeah, so you have to have a vitrectomy done for that, for such patients. So chronic minimal redness pain. So if it's a chronic patient with minimal redness, minimal pain, especially in a child, you have to rule out the juvenile idiopathic arthritis, GIA related iridocyclitis. Look at this eye. This looks very white. There is no congestion in this, but this is a child who has a GIA. There are recurrent attacks of uveitis, but are chronic, are not very, very severe. So the patient is not having any pain, any redness. So this is ignored, and this is a band keratopathy which the patient has developed over the years. So in such patients, you have to have the ANA ESR rheumatoid factor done, and you have to have a slit lamp examination, which is very, very important in these patients. So then the second entity in chronic uveitis comes the herpetic. Usually I told the KPs that the keratic precipitates that accumulate are in the inferior part of the cornea. But if it's a herpetic, if it's a viral cause or a fuchs in this patient, as you can see, the KPs are all over the cornea, also in the central part, and some superiorly also. So these patients are usually of Fuchs heterochromic iridocyclitis, which is a unilateral cause. There will be stellate KPs all over the cornea. There may be any posterior subcapsular cataract because it's chronic, it's minimal pain, and the patient may not be symptomatic earlier. It may be a incidental finding. So in such patients, you just have to do a slit lamp examination. There's not really much investigation you can do about these patients. Post-surgical low-grade end-off because of PE acnes. you have to have a look on IOL. There are brown deposits on this patient, on the IOL of this patient, which is an nidus of infection. What you will do, you will just IOL, explant the IOL, you do vitrectomy, and you give antibacterial drugs, and the patient may respond well. Sorry. Okay. Then comes the intermediate uveitis. Right now we were talking about the acute anterior uveitis. Now the intermediate uveitis may be mild to moderate. There may be, again, sarcoid can be a cause of that. We just discussed what you will do in sarcoid. X-ray you will do, serum A, serum lysozyme, gallium scan, biopsy also you can do. Then tick exposure is very important, especially in the West countries. You have to investigate about Lyme's disease. ELISA is main investigation for that. Any neurological symptom patient is having with the intermediate uveitis, multiple sclerosis has to be ruled out. So MRI you will investigate with the MRI. So these are the white plaques which are seen in the MRI brain, confirmatory of multiple sclerosis. If the patient is above 50 years having recurrent attacks of uveitis and you're not able to find really any cause, just dilate the patient, see the fundus, and you will see these yellow deposits. This is the intraocular lymphoma that patient is having. If what you will do vitrectomy, you'll do the cytology, and you'll just confirm the lymphoma. If it's a pars planitis, which is an idiopathic cause of inflammation of pars plana, there's nothing really you can do, investigate about it. You just give steroids and it responds really well. Then you have the posterior uveitis. Posterior uveitis, it can be chorioretinitis with vitritis and without vitritis. So there's an endless list for that. It may be focal, multifocal, or diffuse. If it's a focal, it can be toxoplasma, toxocara, CMV retinitis. So what you will do in such patients, you have to have the ELISA. So this is a patient with CMV retinitis. Look at these vessels. This is a viral etiology. You have to have ELISA for that. This is ARN, acute retinal necrosis, another viral etiology. And ELISA is the main investigation that you can do about these patients. So toxoplasma, toxocara, all you can investigate with ELISA if it's focal. Okay, we were talking about a single lesion is there, or some part of the retina is involved, other part is okay. Multifocal is there multiple areas of involvement. So if the patient is having shortness of breath, just rule out sarcoid and tuberculosis. You have to have a MON2 and a chest X-ray done. Peripheral retinal necrosis, we just saw the ARN or PORN. You have to have ELISA or possibly vitrectomy, not done nowadays. Then AIDS, you have to rule out syphilis, you have to rule out toxoplasma. Then, I'm sorry. So if it's a diffuse chorioretinitis with vitritis, and you are having some CNS symptoms and dermatological symptoms, you have to rule out VKH, is the Voca and Aguiharada syndrome. Not much you can investigate except for FFA, which is the fundus fluorescein angiography, also in systemic sympathetic ophthalmia, which is rare nowadays, but previously a known entity. So fundus fluorescein angiography, here you can see one patient is sitting on the fundus camera and on the fluorescein angiography camera, and we inject a dye, and we wait for some seconds, and then the dye from the retinal circulation goes to your fundus, and then you have serial pictures. Any inflammation, any leak in the vessels is seen by the various subsequent photographs that you click on these patients on the camera. Then chorioretinitis without vitritis, it is also focal, multifocal, diffuse. Focal is usually neoplastic, metastatic workup you have to do. Others are mostly multifocal, are mostly seen in the West, but commonly seen in India also nowadays. Serpiginous choroiditis, white dot syndrome, mostly fundus fluorescein angiography is the main investigation that you will do in such patients. Also, you can do the autofluorescence, which is the mostly the black photograph of the fundus. Then vasculitis, main is the Behçet's syndrome, Behçet's disease that you have to rule out. There may be after ulcers, hypopyon in such patients. There may be any erythema nodosum or some nodules on the genitals, and there may be recurrent uveitis. So Behçet's, we have seen earlier, is the B5, HLA B5, which you can order, and also SLE has to be ruled out if the patient is a female, has a malar rash or arthralgia. ANA is the main investigation. Also in vaginals. So these are the causes of vasculitis, which is vessels you see in the retina are you see those vessels are inflamed and there is exudates around those vessels. So you have to investigate only if you have a vasculitis in your mind. So that may be vaginals in which you have to order the CNK antiproteinase 3. Yeah, so this is all about all the investigations that you can order. The list is endless, but you have to have a history and examination and yeah, tailored approach to the lab investigation that you order. Okay, thank you guys. Sorry for the delay in the start of the presentation. Any questions, please, you can put in the comment box. I'm assuming no questions. So any questions, you can please mail me. My email ID I'll share with you guys. Okay, thank you.